Hey guys, this is Ben. Hopefully you guys have heard my voice before and I've met all of you guys in person, but if not, you guys have definitely seen some of the emails I've sent, so welcome. Today I just want to talk a little bit about some imaging basics. I know that you guys have all seen this before in medical school and prelim year and maybe just by yourself, but I still think it's important to go over these, have a good foundation for imaging because now you guys are neuroresidents and people in the ED or consulting teams are going to be looking to you as the experts on what to order, when, and why. And so it's good to have a good basic understanding of this stuff. So I think it's worthwhile to talk about this many times. So before we start, we'll have a little introduction on why we get images. I know that seems obvious, but there's a couple points I want to make. The next, we'll talk about different modalities and how we get those images. Not the details of the technology behind it, but how do we get CT scans? How do we get MRIs? Just basically, because that gives us information on what it does and doesn't show, and that's important for when we start talking about pros and cons, so that we know what to order and why. And then lastly, maybe some tips, miscellaneous stuff that I wish someone had mentioned to me when I was first getting started. All right, so let's see, why? Why do we get images? I know that seems obvious, but just need to make the a kind of a maybe not obvious point that we do not get images to localize, right? So we do not get images to localize. It does not replace localizing lesions. We have to look at the patient clinically, think about the signs and symptoms, and connect that to a specific anatomical spot so that we know what to make of the images themselves. The most obvious reason why we have to localize first before we get images is to know what images to get, where to look. Because if a lesion localized to the cervical spine, you got an MRI brain, then it doesn't do you much good. Another point is that these images are very sensitive. They give us a lot of information. And as we get older, we start to get incidental findings and sometimes even things that are kind of irrelevant to the clinical situation, clinical question. There are things called UBOs. I think it's supposed to be like UFOs, like bright object instead of flying object. And a medicine team might get an MRI brain because they think there's something neural going on and there's this bright spot and they ask you what to make of this. And truth is, it might just be irrelevant, it might be incidental. So then, what does imaging tell us? Well, it obviously tells us the etiology of these, of what we're looking for. So let's say we localized something to the left parietal lobe, let's say. Okay, well, we don't treat left parietal lobe lesions, we treat the underlying cause. And whether or not that's a stroke, hemorrhagic, or ischemic, or a space-occupying lesion like a tumor or an abscess, or a demyelinating process, something active going on, et cetera, these all have different treatments. And so, the point is that we first localize, so we know where to look, we know what to get. And then once we get that, we try to make sense of what the etiology is with the images and with the history so that we can best treat the patient. And that's all obvious, but it's important to think about it this way. And I think it's also really important to look at your own images because radiology does miss things. And, I found things that radiology hasn't, and it's not because I'm a better radiologist. I'm not. It's because I had the benefit of the patient in front of me. I clinically knew where to look. If there was going to be anything, it'd be in the right pons, for example, and so that's where I looked. And that's why it's important to do your own reading and also to localize. I guess the whole point of this is that you really just have to localize first and foremost. All right, the first thing to talk about are CT scans, and CT scans are basically just fancy X-rays. So it gets a series of these X-rays, and they assign kind of certain points or pixels on each of these scans, and then it can be re-represented in different orientations. So, axial, and then can be represented as a sagittal or a coronal. But at the heart of it, it's just a fancy X-ray. And what do X-rays do? X-rays look at densities, right? So that's the reason why we say hypo or hyper-dense areas or densities on CT scans. We do not use dense, hyper-dense on MRIs. And we don't describe things on CT scans as hypo or hyper-intense on CT scans. We use hypo and hyper-intense on MRIs. And that's the reason why. It's because we're using an X-ray, and X-rays look at different densities, right? It shoots a bunch of X-rays and they bounce back. And things that are more dense show up as white, high dense, and things that are lower dense kind of pass on through and they're low, and they look black. So what shows up is as black on CT scans. Things like air, water, what shows up white on CT scan, acute blood, and certain metals like calcium. And the reason why we talk about calcium in particular is because it shows up as bone. There are these like gray areas, right? These kind of intermediate areas, that's soft tissue, which CT scans are not very good at distinguishing between. So the things that CT scans are really good at are these areas. It's kind of a good time, I think, to talk about orientation. So on CT scans and MRIs as well, the left side of the screen is the right side of the patient, and on the right side of the screen is the left side of the patient. And the reason for that, well, I'm not sure what the reason, maybe it's historic. Historically, that's just how it was done, but basically it's as if you're looking at the patient from the feet up, right? So, you're kind of looking at him from the feet here, and you're looking up, or I guess just looking at a patient in front of you. But that's important to know, is that it's right's left and left's right. The next modality to talk about are MRIs. And MRIs, like I mentioned, use the word intensity, hypo and hyper intense. And that's because it's all kind of just fancy sequences. And how do we get those sequences? It uses the magnetic properties of the hydrogen atoms and protons, right? The hydrogen, what did I say? I just flipped it around, right? The protons and hydrogen atoms. And hydrogen is obviously in water, and all tissues use water. So you can do a bunch of fancy things like looking at echo and spin and having different parameters and cutoffs to get different sequences. The first sequence is T1. And I like to talk about T1 first because it does basically what the names say they do. So the names, white matter is white, and gray matter is darker, is gray, and fluid is dark. So CSF then is dark. And because of that, it's pretty good at looking at anatomy. So we can look at, we'll take a look at it, I guess, after we finish talking about it. T2, on the other hand, since this is the second one, I think it's like not the original. There's something being done to it. T2, on the other hand, has kind of an inverted appearance. And so white matter is dark, and gray matter is bright, and then CSF is bright. And the reason we use C2 is actually a lot of pathologies show up. It's pretty sensitive for different pathologies. In particular, looking at kind of edema and other things that fluid kind of shows up as. But if you imagine that CSF is bright, then you can imagine some of these areas that I have pictured. I don't know why I'm drawing, but you can imagine that if this is the ventricle, if we're looking at the lateral ventricle and like an axial slice, and you had some pathology here, they might kind of blend together if everything is bright. So what FLAIR does, FLAIR basically inverts the fluid. So it's called fluid attenuated inverse recovery, I believe. And the point being that it inverts the fluid. Let me see. I think I have some pictures of it. Yeah. Okay. So we can just go over this again. T1, basically the white matter is all white, right? The white matter is the thing, the axons and the myelin, and it's white because fat kind of shows up as white. You can see all this stuff here is all fat. It's all bright. And so the fat in the myelin itself is bright, and then the gray matter here, where all the cell bodies are gray. So T1 just kind of does what it says it does. And then again, CSF is dark. T2 inverts it, right? So now if the CSF is dark, then now it's bright. And if all this white matter stuff was white before, now it's dark. And then the gray matter too is now bright, right? So now all this stuff is bright out here. This T2 is being represented as a flare here. This is actually technically T2 flare because you can have a T1 flare too. You can have fluid attenuated T1, which doesn't really make a whole lot of sense because the T1 fluid is dark, but I have seen it. So T2, when we just use the word flare, we mean T2 flare. And so this is basically a very similar image to T2, but now it's basically darkened all this CSF here, right? So now all this CSF is dark, which really helps because now we can see this little like transependymal flow stuff. There's some things as we age, there's this bright areas here that would have bled in on this if we were only looking at a T2. Okay, and then in ADC, what DWI and ADC is diffusion restricting. This is diffusion weighted imaging, I believe, and then ADC is apparent diffusion coefficient, and it's all looking at fluid diffusion restriction. And there's multiple things that show up as diffusion restricting, but for our purposes, the biggest thing is acute strokes, and you can start to see that after a couple minutes. But it has you kind of double check what you find on DWI with ADC. So DWI, diffusion restriction, shows up as white. So that means acute strokes show up as white. And then ADC, acute strokes or diffusion restriction, show up as dark. And I use the word white and dark because it's this middle initial, DWI, W, white, ADC, D, dark. There is a thing called T2 shine through, which because it's similar information that you're getting, T2, things that are bright on T2 also show up bright on DWI, but not on ADC. So that's why you have to double check. Make sure that it's not just T2 shine through, it's actually diffusion restricting. If someone uses the word diffusion restricting, that's what they mean. They mean white, bright on DWI, and dark on ADC. And then kind of the last sequence to talk about right now is GRE or SWAN. Our system uses the word SWAN. GRE, though, it basically looks at hemosiderin deposition or deposits, and basically what it's looking at is for old blood, any evidence of blood. And so you can see some vessels, because it actually doesn't have to be old, it's just kind of any age blood, it's hemosiderin. So vessels carry blood, and so you can see them sometimes, but with all of the tissue being white, the areas of hemosiderin, kind of old blood or blood that shouldn't be there, shows up as black. It's very obvious when you see it. Let me see, I think I also have that picture of that here somewhere. Yeah. So that you can see here, this is a vessel with the arrowhead that's on the right side, and then the arrow with the full arrow, you can see these dark spots, and these are areas of old blood hemorrhaging. An important point to mention is that there's a thing called blooming artifact. And blooming artifact, basically, the way that we actually pick up this deposit is through a process that looks at artifact. So blooming artifact just says that basically this area here is not the size of the bleed. It just says that there is blood there, and the artifact is kind of making it bigger than it looks like on volume, but that there is blood that used to be there. All right, now talk about contrast. CT scan uses an iodinated substance, and MRIs use this paramagnetic substance called gadolinium. Sometimes you'll hear people just call it GAD. They're both technically nephrotoxic, but iodine more so, and gadolinium less so. Less so much that we do use it in CKD patients if it's indicated. But because it's technically nephrotoxic, CT iodinated, we do check creatinines and look at GFRs for these patients beforehand. But sometimes the risks outweigh the benefits outweigh the risks in patients like and like stroke codes. If we're concerned if the clinical situation looks like a large vessel occlusion and we think that they might be able to go to a mechanical thrombectomy, then we'll get a CT scan with contrast to look at the vessels. Which actually, I guess, kind of gets to another point. You can get CT with and without contrast. You can go to, which is different necessarily. Not necessarily the same thing as a CT angiogram, which looks at blood vessels. And another way to look at blood vessels is an MRA. CT angiogram, as I mentioned, uses contrast. MRAs do not, right? So there's no contrast involved with MRAs, and the reason why is that just like MRIs, it kind of uses fancy the magnetic properties of protons and looks at the things that are moving. If the patient's staying still, then the only thing that's moving should be like blood and blood vessels, and so it'll pick up it'll see what's moving. And you can imagine if things are moving maybe quicker or less fast in certain areas, that there might be it may not be able to represent this vessel as cleanly as if you had just filled the whole area up with contrast, like you do in a CTA. So, I mean, MRAs are not the gold standard. Actually, CTAs are. They're the gold standards for looking at blood vessels, but MRAs are good when you're worried about contrast, and also if they're already getting an MRI. If they're already getting set for an MRI brain, for whatever reason, to evaluate for a stroke after the stroke code, after they've already been admitted, and they didn't get blood vessels, you can get an MRA as well while they're down there. So then, why do we get contrast? When do we give gadolinium for MRIs? Well, I mentioned before that it does give us a lot of information about some other things. So this is, let's say this is a T1. This is a T1, this is T2, this is T1 post, T1 pre. So you can see here, this is all that white matter. As I mentioned before, white matter with T1 looks white. All this stuff looks here, it's all dark. Should be white matter, but it looks hypo-intense. And the reason for that is edema is actually showing up a little bit hypo-intense on T1 and really bright on T2. So you can see here really obviously all this vasogenic edema on T2. And then you can see there's this like mass hanging out here. And after you give contrast, that mass has this rim enhancing area, and that's why we will call it a rim enhancing lesion. That's what we mean. It shows up bright. Yeah, it's rim enhancing. It's a rim around, and it's enhancing because it's bright. But I guess what shines up bright with? I guess what does enhancing mean? Why is it showing up bright? And the reason is basically it's any process that's destructive in the sense that it's breaking down the blood-brain barrier. So blood-brain barrier breakdown leads to this enhancing. And if you have a lesion that's breaking down the blood-brain barrier around it, like I think this was a lymphoma, then you get a rim enhancing area. All right, so now that we've done all that, we can talk about the pros and cons. Might be a little repetitive since I kind of got ahead of myself before, but the pros for CT scan are the same as the pros for x-rays because it's basically a glorified x-ray, right? So we know the x-rays are fast. The x-ray tech, steps out of the room for a second, says hold still, and presses the button. It's instantaneous. I guess CT scans aren't instantaneous because it's taking a series of x-rays, but it's still very fast. It takes a couple minutes. And that's good for things that are acute or, being evaluated for surgery. Another thing that it's really good at is looking at things that are dense, right? So blood and bone. Blood being, if someone's a TPA candidate, we need to make sure that it's not hemorrhagic because a hemorrhagic stroke is a contraindication for giving TPA. And for bones, it's really good at looking at fractures, which for the most part we're not going to be called first, right? Trauma is. But you do see non-accidental traumas in children at CHLA, which kind of gets us actually to a con. Let me do this in a different color for a second. One of the cons is that it has radiation, right? So we try to avoid it in children and pregnant ladies. And also it doesn't look at soft tissue very well. But MRIs do, so it's kind of, the opposite. So it does not use radiation, and it looks at soft tissue really well. We talked about that. Very sensitive. For lots of different pathologies. And then the cons for MRIs are basically the pros to CT scan, or the opposite of that, right? So MRIs are slow. They require someone to lie down flat for extended period of time. So in patients who are claustrophobic, might be difficult to be in a small tube for a period of time. People who can't follow commands, like those that are demented, can't follow commands very well. Or those that are agitated, like those who are intoxicated. These all might be tough to get because they're so slow. And they can take, a little less than an hour or more than an hour, depending on how many sequences and which sequences you use. And then the other content, MRI, is it doesn't really look at acute blood very well. I mean, there's GRE and stuff, but it's kind of ties in with it being slow. It takes a long time. All right, I just have some images here to kind of show some of the pros and cons to CT. So we know this is CT, right, because the bone is all bright here. What else shows up bright on CT is acute blood. So this is an epidural. This is acute blood, and we know it's an epidural, right, because it has this lenticular lens-like shape. The sutures here are anchoring the dura, so it kind of doesn't have anywhere to go. It shows up very bright and very obvious. But if you weren't so astute, you might miss a subacute bleed on this side. There's a subdural. If you look really closely, you might see a little bit of a difference in density from here to here, but it's very hard to tell, right? It's hard to tell with soft tissue. And this is now isodense. It's a subacute bleed. It's a subdural. And we definitively know that this is a subdural because it has a mass effect. It's pushing the brain over, right? You can see this midline is being pushed over with after this is all filling up with some blood. And in addition to seeing that it's being pushed over, you also can see some of the compression of some of these structures, right? So this ventricle, the right ventricle, is a little bit smaller than the left ventricle. The occipital horn of the lateral ventricle is existent on this side, but essentially non-existent on this side. You have a little Sylvian sulci is basically gone here. So some of the pros and cons of CT, and we talked about how CT is not good at showing soft tissue, but in particular, it's really bad at showing the posterior fossa. One of the reasons why is because all this bone, again, bony, so you know it's all bones, right? So you know it's a CT scan. The posterior fossa is surrounded by bone, and so you get this like artifact. Until maybe it's like tough to get those X-rays through the bone, so you get all this artifact. This is actually from the air artifact, but regardless, you get all this artifact, and it's tough to tell what's going on in this back area. And I guess while we're looking at CT scans, I can just show you again. This is CT. This is bone on the outside, but do we have bone on the in the middle of the brain, deep down? No. So what else shows up bright? It could be blood, but it's too bright, and after you see this, you'll never kind of mistake it for blood again. It's actually a calcium deposit. There are some areas of the brain that get calcium deposits. Most commonly, it's like choroid plexus, but sometimes the basal ganglia also gets a little bit calcified as we age. This in particular is the pineal gland. The pineal gland is this mid-structure, and as we age, it starts to calcify. And this is already pretty long, so I don't know about tips or tricks necessarily if I really have that much to offer. But I mean, I think a couple of things maybe are looking at spine, I guess. Or I guess how we set up images. Yeah, so instead of talking about spine first, we can talk about how you set up images when you take a look at them, right? So when we take a look, you can, on the computer, you create these 4 quadrants. And then some people do it a little bit differently, but I like to do DWI, ADC, FLAIR, and then GRE. If you're looking for things that there's stroke or diffusion restricting is on our differential. Because you compare it to ADC, FLAIR gives us a lot of information, and always good to make sure there's no blood. One of the other things is that it's oftentimes best to use your whole screen, since we don't have very big screens, to just kind of look at one thing in particular. So it might be worthwhile to just look at DWI first to see if there's anything bright, and then change it to ADC. But for the most part, people use that quadrant system. Another thing I guess if you're having contrast too, so that's another thing. I guess if contrast is another one, then you can still do the 1, 2, 3, 4, like I mentioned before, with DWI, ADC, FLAIR, and GRE. But then you also have like a pre and post, or however you want to do it. Different ways of, or pre, post, FLAIR, GRE, however you want to do it. But then that kind of gets us to spine. And spine, we don't look at it quite as much as the brain, so it is sometimes a little bit intimidating or kind of tough to tell. But the best way that I found is to put everything into STIR, because STIR is basically the equivalent of FLAIR or T2, one of those, FLAIR or T2, and then have a sagittal here and an axial here. So then you're looking at, you try to do a mid-sagittal so that you know on what level you are when you're actually scrolling through on the axial. So as you're scrolling through on the axial, this kind of goes down, and you can kind of tell what level you're on. We didn't include it here, but basically this, I have here, I included this just to show like some of these T2 areas in an MS patient in spine. But this, you can imagine this might be like on the left side of the screen, on the right side you're looking at axials, individually axials. And I guess since I have this up, just to show you, this is like an pretty advanced MS patient here, showing a lot of plaque burden, right? So these are all kind of plaques here. Some of this is maybe microvascular and transependymal and stuff, but this is definitely plaque and in this patient, most consistent with an MS with multiple sclerosis, advanced multiple sclerosis. But actually, kind of getting back to an old point maybe, I mentioned this is FLAIR, and you can see all this white, all this signal, this hyperintensity here. Imagine if this was all white too. It would all kind of bleed in and merge together and be tough to tell what that burden actually was. So that's nice that I was able to kind of tie that back in, I guess. And so just kind of something to talk about too. So here you can see this is bright. This is post contrast, I believe. So you're seeing it show up enhancing this optic nerve. You're not seeing it enhance on this side, and it's dark here. Just you'll see these images, but I guess while I'm talking about MS, show the optic nerve, and that's it. I think we did some basics. We said why we get it, what the purposes are, how the images are obtained, so that we can talk about the pros and cons, and then it just kind of rambled for a little bit, but just I guess some other little points to make. This is the first time I'm doing this talk, so I'm assuming it'll continue to get better. So thanks for sticking with me. It's a little bit longer than I had intended as well.